All right, so we're going to talk about myasthenia gravis and Lambert-Eaton syndrome, two really high-yield neuromuscular conditions you're going to want to know for test day and beyond. So we'll discuss neuromuscular transmission, the sarcomere cycle. Both of these will be really high yield for step one. And then we'll discuss the presentation, pathophys, management complication of both myasthenia gravis and Lambert-Eaton. And then we'll do two putting it all together cases. So this was the case I presented on Instagram. So let's flesh it out. We have a 62-year-old man presented with 3 weeks of progressive muscle weakness. He reports double vision and drooping of his left eyelid, which worsen as the day progresses. He denies difficulty swallowing, shortness of breath, or leg weakness. On exam, he has a left ptosis and limited upward gaze, both of which worsen with sustained upward gaze. Strength is 5 out of 5 in all limb muscles except for mild weakness, 4 out of 5 in shoulder abduction bilaterally. There is no leg weakness and deep tendon reflexes are normal. So my question for you is, which of the following features in this patient's history and exam most strongly increase the positive predictive value for a diagnosis of myasthenia gravis compared to Lambert-Eaton? Is it fluctuating muscle weakness, normal deep tendon reflexes, initial and predominant ocular muscle weakness, or proximal arm weakness? So pause your screen, think about it, and then we'll move on. So in this case, it's definitely going to be the initial and predominant ocular muscle weakness. So that is, so like the muscle weakness would cause ptosis, drooping of the eyelids, and then diplopia. We could have actually double vision. It's highly characteristic of myasthenia gravis, and it's rarely, if ever, the presenting feature of Lambert-Eaton myasthenic syndrome. So in contrast, Lambert-Eaton usually always presents with proximal muscle weakness in the legs and rarely involves the ocular muscle at onset, and then Lambert-Eaton likes to ascend upward. It's multiple studies. I've got the I forgot to link the studies here, but I've got them at the end of the slide, so you can go read into them if you'd like. But really, when I think about fluctuating muscle weakness, that's a hallmark of myasthenia gravis, because it gets worse as they exercise and then gets better as they rest. And we'll talk about why near the end, but it's not specific to myasthenia gravis. That's the problem. It can be seen in Lambert-Eaton, and it can be seen in other neuromuscular junction disorders. Normal deep tendon reflexes are pretty typical in myasthenia gravis, and Lambert-Eaton is characterized by reduced or absent reflexes that may improve after exercise. However, the normal reflexes are not exclusive to myasthenia gravis, and they can be seen in other conditions as well. So it really doesn't kind of push the needle too much on myasthenia gravis over Lambert-Eaton. And it's definitely not as predominant of a finding as those ocular findings right off the bat. And then the proximal arm weakness can occur in both myasthenia gravis and Lambert-Eaton. So myasthenia gravis usually starts in the face, the bulbar muscles, the eyes predominantly, and then can descend downward and especially impact the arms. Usually spares the legs. Sometimes it can impact them. So really, with this question, MBME can never ask you something like this on step. The reason I kind of like phrase the question like this is to teach you the concept, right? A lot of my questions aren't written directly like MBME is going to do it on the exam, and it's for a reason. I don't need to ask you the same questions you're going to see over and over and over again on UWorld and AMBOSS. My job is to teach you how to think about these diseases. So the reason I ask this question is because now you're never going to forget that myasthenia gravis, you should think about it more than Lambert-Eaton syndrome when you see the patient with the diplopia and the ptosis that starts early in the disease rather than proximal leg weakness early in the disease. Okay, that was the whole point of this question. It's a tough one, okay? So again, lots of studies have shown, and I've got them at the end, that the predominant early finding of ptosis diplopia increases the positive predictive value in a patient with myasthenia gravis, pointing me more towards myasthenia gravis than Lambert-Eaton. And so this is an aside. I hate talking about statistics, but it's kind of necessary for this. So the positive predictive value is the probability that a person with a positive test actually has the condition being tested for. We calculate it by dividing the number of true positives by the total number of positive results. So we take true positives and we divide that by true positive plus false positive. So in our example, right, let's say the patient has early predominant ocular findings and we do blood testing and we see a positive acetylcholine receptor antibody. Okay, we're going to talk about that antibody coming up. The early and predominant ocular findings increase the likelihood that that acetylcholine receptor antibody was a true positive, right? if the patient showed up and they had proximal leg weakness first, and they had a bunch of other symptoms, but they had no early eye involvement, and the acetylcholine receptor antibody showed up positive on that patient, I'd be a little more skeptical that that's a true positive. But the fact that the patient had the diplopia and the ptosis early on, and we have the acetylcholine receptor antibody that's positive, that now points me more towards a diagnosis of myasthenia gravis. And again, that's kind of what our case was getting at. All right. So let's talk a little bit about physiology, because if we understand the physiology, we'll understand the pathophys. And if we understand the pathophys, we'll understand the workup and the management. Again, you should do this for every single disease you discuss for the rest of your life. So neuromuscular transmission, we start at the presynaptic neuron, and I have a picture coming up. Our action potential arrives at the axon terminal. That action potential causes the opening of voltage-gated calcium channels. That calcium influx into the axon terminal causes the release of acetylcholine vesicles into the synaptic cleft, right? Those are by those snare proteins. At the synaptic cleft, acetylcholine diffuses and it binds to the nicotinic acetylcholine receptors on the motor end plate. And now that we're on that motor end plate, the acetylcholine binding causes sodium influx and depolarization. That depolarization travels down and then down the T tubule. And when it travels down the T tubule, it causes the calcium release from the sarcoplasmic reticulum by opening up my ryanodine receptors, and then calcium floods in to the inside of the muscle, and it binds to troponin C, and binding to that troponin C disinhibits the actin-myosin interaction, and we can start getting our contraction. I've got pictures of all this coming up. So again, the action potential goes to the axon terminal. It causes the opening of the voltage-gated calcium channels. That calcium causes acetylcholine vesicle release into the cleft. Acetylcholine then binds to the nicotinic acetylcholine receptors. The acetylcholine binds. It causes sodium influx and depolarization that goes down the T tubule. That causes the ryanodine receptors to open. Calcium floods out of the sarcoplasmic reticulum. It'll bind to troponin C, and we'll start our sarcomere contraction cycle. So again, in picture form, the neurotransmitter molecules are synthesized and packaged into the vesicles. The action potential arrives at the presynaptic terminal. The voltage-gated calcium channel receptors will open. Calcium floods in. It causes these synaptic vesicles to fuse with the membrane. Acetylcholine will then get released out into the cleft. It'll bind to these postsynaptic receptors and trigger the action potential on the postsynaptic membrane, and then the neurotransmitter gets broken down, which we'll talk about in a second. All right. So how does this sarcomere contraction cycle work? Well, the key steps, right? It's an ATP-driven process. We're in our resting state, so tropomyosin blocks the myosin binding sites on actin, okay? Now, here's where we left off. Calcium binds troponin C, and it moves tropomyosin off of the myosin binding sites on actin. So now actin can bind to myosin because we've removed the lock on myosin. So here's myosin, here's tropomyosin. When calcium binds to troponin C, it moves tropomyosin off. So now myosin is free to bind with actin, all right? So the myosin head then binds to actin, and we do our power stroke. So ADP plus PI are released. So we take ATP, we convert it into ADP and free or inorganic phosphate, and they get released. That causes a huge amount of energy to be released. The myosin head will pull the actin, and that actually causes the contraction. So then the ATP, a new ATP molecule, will bind myosin. That will cause the myosin head to detach from actin. The ATP gets hydrolyzed, and the myosin head recocks, and we're ready to start again. So again, ATP is required to detach the myosin from the actin. Rigor mortis, when your body is extremely stiff after you pass away, it occurs because there's no ATP available to release the myosin head, so the patient just stays in full contraction, okay? This process repeats as long as calcium and ATP are present. So again, in our resting state, tropomyosin blocks myosin. When calcium binds to tropomyosin, it moves tropomyosin off of the myosin, okay? So now myosin's free. It can bind to actin. When it binds to actin, ATP gets hydrolyzed into ADP and inorganic phosphate. Those get released, and it pulls, the myosin head will pull actin. That causes that contraction. ATP will then bind myosin the myosin detaches from the actin, the ATP gets hydrolyzed, and the myosin head recocks, and we're ready for the next cycle. And again, I've got it in picture form here. So again, here's how it works. I like starting at actually the end first. So as the myosin head binds ATP, the cross bridges detach, okay? So they're now recocked into their original position. In step 1, the myosin heads hydrolyze ATP and become reoriented and energized. So we've got our ADP and inorganic phosphate here. The myosin head binds to actin, boom, right here, and it forms that cross bridge. Here we've got our ADP. We lost that phosphate. In step 3, the myosin cross bridge rotate toward the center of the sarcomere. They do that power stroke. And then we release the ATP, and as the myosin head bind ATP, the cross bridges will detach and we'll start over. Again, lower yield for step 1, but I think understanding, the neuromuscular transmission is really important, and understanding the role calcium plays in all the sarcomere contraction is also really important too. That's the reason I went over. And then how does muscle contraction stop? Well, we need to break down acetylcholine. So that's by acetylcholine esterase. So sitting in my synaptic cleft here are acetylcholine esterase, and it does exactly what it says. And esterase is going to cleave the acetylcholine, so it's no longer functioning. Okay? So it rapidly degrades acetylcholine into choline plus acetate, right? It cuts it in half. That stops acetylcholine from being able to bind to the postsynaptic receptors, so it stops the end plate depolarization. So there's no more action potentials and no further calcium release. Calcium, we have to take care of itself too, so we get reuptake into the sarcoplasmic reticulum. So we have these SERCA pumps. They actively transport calcium back into the sarcoplasmic reticulum, so back into your jail cell, right? Calcium levels fall in the cytoplasm, and then in step 3, our troponin tropomyosin block is reinstated. So without calcium, troponin C loses its calcium. So remember, it's tropomyosin sitting on actin, sitting on myosin. Troponin C sits on tropomyosin. When troponin C doesn't have its calcium, it stays locked in. When troponin C has its calcium, it moves, and then tropomyosin will move off, and we've got a free myosin, okay? But without that, troponin C is staying locked in on tropomyosin, so we can't do that cross bridging anymore. And then it's an ATP dependent reset. So the myosin heads unbind and reset with the ATP hydrolysis that we just talked about. The muscle relax and we return to the resting state. All right. So now we have a good idea of how neuromuscular transmission works, how the sarcomere contraction cycle works, and how the muscles, how we actually break down acetylcholine and we stop the muscle contraction. All right. So now we can get into what do we actually care about, the 2 diseases that we came here to learn about. So myasthenia gravis, these are step 1 must-know basics, okay? So the core mechanism, we have autoantibodies that block the nicotinic acetylcholine receptors at the postsynaptic neuromuscular junction, preventing effective signal transmission. So right here, we have antibodies that are blocking acetylcholine from binding. So you can think about how this would show up, right? The acetylcholine is not able to bind, so we're not able to do effective muscle contraction. And it classically will start in the face. You'll have drooping of the eyelids, so my facial muscles get really weak. Drooping of the eyelids and some of those eye muscles get weak, so we can get double vision too, all right? So we'll flesh this out further. So the type of the disease, right, it's an autoimmune disease. Remind me again, if these are autoantibodies, would this be considered a type 1, type 2, type 3, or type 4 hypersensitivity? So autoantibodies are a form of type 2 hypersensitivity. Remember, type 1 are IgE mediated or allergic reactions. Type 2 are the autoantibodies. Type 3 are the immune complexes, and type 4 are the delayed T cell. So the target, again, is acetylcholine receptor on the postsynaptic membrane. The muscle weakness is fluctuating and it worsens with use. So there's fatigability. Okay, and we'll talk about why. I've got a whole slide on it. The classic presentation is ptosis, diplopia, and facial weakness first, and then it can descend. Okay, reflexes and sensation are usually normal, so it helps me tell that it's not a neuropathy. My peripheral nerves are intact. Improvement with with rest, absolutely. Okay, and we'll talk about that again coming up. Antibody tests, we're going to look for the anti-acetylcholine receptor antibodies. Those are the most common antibodies found, right? And then we can do what's called the tensilin or the edrophonium test. It's kind of a historical test. We don't really do it as much, but basically edrophonium is an old acetylcholine esterase inhibitor. So I would give the patient a small dose in the clinic that acetylcholine esterase inhibitor blocks the acetylcholine esterase in my cleft, and you can think about what would happen, right? Acetylcholine esterase is what's cutting up acetylcholine. We blocked the enzyme that cuts it up. So more acetylcholine is able to stay in the synaptic cleft, and it builds and it builds and it builds. And when it builds to a high enough level, it can outcompete the acetylcholine receptor antibody that's found on these receptors. All right. So it used to be used, it's not used as much anymore. But if the patient had a increase or improvement in their weakness, that would be a sign maybe pointing me towards a myasthenia gravis diagnosis. So let's get a little bit more advanced here, right? So these are advanced diagnoses and management. So what's the distribution of weakness? Remember, it's going to be eyes, the face, the bulbar. So dysarthria, they're going to have maybe a hard time speaking. Their words are going to slur, and they might have dysphagia. It would be a form of oral pharyngeal dysphagia. I'll do a whole lecture on dysphagia, but I separate dysphagia into oral pharyngeal and esophageal. So when I think about oral pharyngeal dysphagia, that's when the patient has a hard time initiating the swallow or the food gets stuck more up in the pharynx. Whereas in esophageal dysphagia, the food either gets stuck more in the esophagus or like behind the sternum where that esophagus is draining into the stomach, um, or the food has a hard time moving through. So it either gets like stuck or it has just a really hard time getting through. So when I think about oral pharyngeal dysphagia, I can think about structural. Okay, so is there an actual structure that's blocking food from getting from the oral pharynx to the esophagus? Or is it a dysmotility problem, right? And I can break that dysmotility problem into neurological and muscular, right? And myasthenia gravis would be a form of muscular dysmotility affecting the oral pharynx, okay? And again, I'll bring this down further into my dysphagia lecture. Dysphagia is one of my favorite topics to talk about because it's very complex and it's a very broad differential. And just a few questions, I can figure out exactly what's going on with the patient and what my next step should be. But again, so these patients with myasthenia gravis might have a hard time initiating their swallow. Food shouldn't really get stuck, but they'll have a hard time initiating the swallow because it's a neuromuscular problem. It's a dysmotility problem. Okay, and we can have weakness of the neck and the proximal limbs because it starts at the eyes, can move down to my oral pharynx, move down to my neck, move down to my proximal limbs. Okay, exacerbating factors. I've got a slide on myasthenia crisis, but really there's things like infection, pregnancy, stress, certain drugs like aminoglycosides, fluoroquinolones, and beta blockers can all exacerbate myasthenia gravis. There's something called myasthenia crisis, which again, I have a full slide on that we'll talk about next. But this is advanced myasthenia, right? So myasthenia gravis gets exacerbated and it puts them into respiratory failure because now we're impacting the diaphragmatic muscles and my diaphragm's not working. That's my major inspiratory muscle. The patient is going to need probably intubation, and then they're going to need massive amounts of IVIG and plasmapheresis to take care of those antibodies. Okay, slide coming on myasthenia crisis next. There is a connection with thymoma or thymic hyperplasia. So roughly 10 to 15% of all patients with myasthenia gravis have a thymoma or some sort of thymic hyperplasia. So a classic step 2 question. You have a patient with myasthenia gravis. Maybe they tell you they've made the diagnosis or they at least hint at it, right? They key you in and they say, what's the next best step? And everyone's going to look for the acetylcholine esterase inhibitor. They're going to look for pyridostigmine, and that's not an option. And they're going to have a bunch of imaging tests, right? You're going to want to get the chest CT because we're going to want to see, hey, does this patient have a thymoma? Because if they do, we can resect the thymoma and that might make the disease better, right? Because sometimes the thymus, that thymoma or that thymic hyperplasia can disrupt my whole autoimmune process. Remember, that's where my central and or my central tolerance, right? My positive and negative tolerance occurs. And so if we're messing with my thymus, that whole process can get abnormal, and that's how we can make those acetylcholine receptor antibodies. All right. There are a few other antibodies that coexist. So there's this anti-MuSK, muscle-specific kinase. That is often associated with the facial and bulbar predominant. So if you're ever reading a question, it's myasthenia gravis, and you're looking for them to say something about the acetylcholine receptor antibody, and it's not there, they might be getting at the anti-MuSK, right? So it's another antibody that's associated with myasthenia gravis. We can do what's called the ice pack test. If I put the ice pack on the ice pack actually slows the activity of the acetylcholine esterase. And so instead of us cutting up the acetylcholine, it slows it down. So we get a further buildup of acetylcholine in the cleft. And we usually put it on the patient's face for 30 seconds to 2 minutes. And when they remove it, hey, if their ptosis is a little bit better, if their vision is a little bit better, it pushes me a little bit more towards myasthenia gravis, right? It improves the positive predictive value, like we talked about. So that's just like a quick bedside exam. We could do electromyography, so a decremental response with repetitive stimulation, because remember, myasthenia gravis is going to get worse as we stimulate the muscle. And again, the reasoning, I have a whole slide on it because I want to explain the pathophysiology side by side from myasthenia gravis compared to LEMS. But just remember, myasthenia gravis gets worse as the patient moves around and does activity. So when I do the EMG, they're going to have a decremental response in the way the muscle's firing as they progress. And then there's coexistent autoimmune conditions, right? Autoimmune conditions love to run together. They love to run in families. So maybe mom has a history of type 1 diabetes, brother has a history of Crohn's disease. It increases the likelihood that this patient may get an autoimmune condition. And it can run with other immune conditions in the patient themselves. So again, treatment, acetylcholine receptors, pyridostigmine is usually the go-to. I remember it because myasthenia gravis, the second letter is a Y. The second letter in the acetylcholine receptor we use is pyridostigmine, also a Y, because there's drugs like neostigmine and physiostigmine, and they're used for different things. So again, the one with the second letter Y is used for myasthenia gravis because myasthenia gravis also has the second letter Y. That's how you can remember it. We can do immunosuppression with steroids, azathioprine or mycophenolate. We can use IVIG or plasmapheresis for those crisis or severe flares. And then remember, thymectomy is probably going to be indicated if we find it, if there's a thymoma, or if they have generalized myasthenia gravis in a patient less than 60. That's also an indication to remove that thymus or the thymoma, right? Okay. So what is myasthenia crisis, right? We've kind of already talked about it, but it's an acute worsening of myasthenia gravis causing respiratory failure because we've impacted the diaphragm due to diaphragmatic and bulbar muscle weakness. It often requires intubation plus the ICU care, right? We're going to need to escalate the management of care. So what do? We protect the airway, okay? Often I've seen questions like this if the patient presents in like something like Guillain-Barré or myasthenia crisis, where we get really worried about in myasthenia crisis, it'd be descending paralysis, and Guillain-Barré would be ascending paralysis. I worry about the diaphragm. We can get the FVC, so the patient breathes in maximally and then exhales maximally. We can see what that level is. If the patient dips below 15 to 20, we're concerned about some sort of diaphragmatic injury here, so we'll probably intubate. We can do short-term rescue with the IVIG or plasmapheresis. We'll hold the pyridostigmine because that can actually worsen the secretions in the intubated patients. So remember, pyridostigmine is going to inhibit acetylcholine esterase, which leads to increased amount of acetylcholine throughout my entire body, not just at the neuromuscular junction. Acetylcholine esterase is found everywhere. Remember, acetylcholine is the king of my parasympathetic nervous system. What does my parasympathetic nervous system do? It's rest and digest. That's going to lead to a lot of secretions from the salivary glands and throughout the rest of their body, and especially my salivary glands and my esophagus and my pharynx. We don't want those secretions because that can cause a lot of problems in intubated patients. They can aspirate, cause aspiration pneumonitis or aspiration pneumonia. And then we'll treat the trigger, right? So what are the common triggers? Infections are very common. These are what's going to show up on your USMLE step exam and show up in real life often too, obviously with infections. Aminoglycosides, fluoroquinolones, beta blockers, okay, magnesium, a classic question on OBGYN. They love asking about this. We do not give magnesium to patients with myasthenia gravis. Or maybe the patient has undiagnosed myasthenia gravis and we give magnesium and it kicks them into a crisis or it kicks them into a full-blown myasthenia gravis. Anesthetics and neuromuscular blockers. Really things you need to look out for. Magnesium is given in preeclampsia to prevent eclampsia. So be on the lookout for that. Post-op states, anesthesia, pregnancy. In and of itself, pregnancy can cause an autoimmune shift, right? All these different hormones, you've got baby's blood mixing with your blood. It's just asking for an autoimmune condition to occur because our immune system is going to see novel things it's never seen before and it might overreact. So this is a common step question where the patient will be a couple weeks postpartum and all of a sudden show up with like multiple sclerosis or myasthenia gravis or lupus or thyroiditis, things like that, right? So think about if we had a preeclamptic patient who was just pregnant, they just gave birth a couple of weeks ago, man, and so we had to give them magnesium and they had all these pregnancy hormonal shifts and autoimmune variations. The immune system is kind of getting revved up. It's just asking if the patient has underlying autoimmune problems, right? That were maybe masked, it's going to unmask them, right? Um, Sometimes tapering immunosuppressants like steroids can unmask this, and then certain stresses, so trauma and hospitalization. So again, myasthenia crisis, you're going to want to really look out for the drugs. Aminoglycosides, fluoroquinolones, beta blockers, and magnesium are going to be the biggest ones. Certain infections. We're going to see the patient's going to have impending respiratory failure. Get an FVC on them if they're less than 15 to 20. Airway protect, IVIG or plasmapheresis, and hold the pyridostigmine, and obviously treat the trigger. All right. So that's myasthenia gravis. Let's move on to Lambert-Eaton. So what's the must-knows, right? This is an autoantibody that attacks the presynaptic voltage-gated calcium channels at the neuromuscular junction, and it impairs acetylcholine release. So if we look here, the action potential is coming in. We have these voltage-gated calcium channels that open that allows calcium to come in, and when the calcium is high enough, we get calcium-dependent exocytosis, where these snare proteins fuse against the membrane and they release acetylcholine. In this disease, we have antibodies right here. So they're inhibiting the calcium from ever entering. When the calcium can't enter or can't enter as effectively and efficiently, we have a harder time fusing this vesicle and a harder time releasing acetylcholine. So in myasthenia gravis, it was blockade here. We could release acetylcholine just fine. In Lambert-Eaton, there's a problem getting the vessel to fuse due to a lack of calcium. If the acetylcholine leaks out, it can totally bind to the postsynaptic receptors perfectly fine, and the patient will have a perfectly fine muscular contraction. All right. The problem is getting the acetylcholine out. That's the problem here. All right. So what type of disease? Again, it's autoimmune or it could be paraneoplastic. We'll talk about that in a little bit. It's the presynaptic voltage-gated calcium channel, which leads to decreased acetylcholine release. The muscle weakness is classically in the proximal limbs, especially the legs. So I like asking my patients, are you able to stand up out of a chair okay? Can you climb upstairs as easily as you could? Right? I ask them, can they brush their hair? Can they reach for things at the top shelf? That gets at my girdle muscles, my shoulder and my hips. The classic presentation, again, here, literally right here, difficulty rising from a chair, climbing stairs, dry mouth, because we often see autonomic symptoms. So we could see dry mouth. We could see meiosis. We could see kind of like our Horner syndrome type picture, right? So ptosis, meiosis, and hydrosis. I might be looking out for those. The reflexes will be reduced or absent, but they may improve after exercise. So again, we'll talk about why. Is there improvement with use? Yes, because the strength improves with repeated contraction. And again, I'm going to flesh this out in just a bit, so stay patient with me. And the antibody test, right, we'll see in about 85% of patients, they'll have the anti-voltage gated calcium channels antibodies. So let's kind of progress the management a little bit and get a little more in depth. It is associated in small cell lung cancer in about 50 to 60% of cases, right? So if the patient has Lambert-Eaton syndrome, just like I talked about with myasthenia gravis, we should get a chest CT. We should do the same thing if we diagnose them with Lambert-Eaton syndrome, because about more than half of them will have small cell lung cancer that's secreting these voltage-gated calcium channels causing Lambert-Eaton. Okay, again, symptoms, we see proximal leg weakness, we can see hyporeflexia, we can see the autonomic symptoms, again, dry mouth, impotence, constipation, kind of things like that. Distribution, legs more than arms, but the arms can absolutely be impacted. We can see bulbar and ocular symptoms, but they're way less common than myasthenia gravis. The reflexes, again, are often absent, but they can return after brief exercise. Fatigue versus facilitation, the Lambert-Eaton improves with use. Myasthenia gravis worsens with use. It's literally on my next slide, so we'll talk about it. But maybe you're probably catching on to why now, right? If you understand the physiology and pathophys. The EMG will show the incremental response. So remember, with the EMG with myasthenia gravis, it got worse as we kept stimulating the muscle. With Lambert-Eaton, it will actually get better. So my approach, we treat the underlying cancer. So usually it's small cell lung cancer. So let's treat that. Small cell lung cancer, we usually have to do chemo. Surgery is usually not an option. Symptomatic treatment, we can use this drug called 3,4-DP, which enhances acetylcholine release. We can do immunotherapy if it's an autoimmune process like steroids, IVIG, and plasmapheresis. And then again, remember, if we diagnose them with Lambert-Eaton, right, they have proximal leg weakness at the hip girdle, they have dry mouth, they have constipation, they're a long time smoker, they're an older male. I get the chest CT, right, and we see the small cell lung cancer, all right? So the thing I've kind of been alluding to all this time, why does myasthenia gravis get worse with use? And Lambert-Eaton gets better, right? Really simple, because we have built a really nice foundation of the physiology and pathophys, right? So remember, in myasthenia gravis, it's the autoantibodies that block the postsynaptic acetylcholine receptors. So what happens with repeated use is each stimulation releases normal acetylcholine, right? We had no problem there. But fewer working receptors means there's less for the acetylcholine to bind to, right? So they get progressively weaker, and it leads to fatigability. With Lambert-Eaton, we have autoantibodies that block the presynaptic calcium channels that impair the acetylcholine release. Here, every time the muscle is stimulated or it contracts, the calcium is going to get released via the ryanodine receptors opening up and leading to release of calcium from the sarcoplasmic reticulum. So as that calcium builds up, it's able to outcompete the voltage-gated calcium channel blocker, and it allows more acetylcholine to be released, which allows us temporary strength improvement. So again, here in myasthenia gravis, we have blockade here. Anytime the muscle contracts, we're going to get way more calcium into the muscle, but it's not necessarily going to lead to more acetylcholine in the cleft. And so that acetylcholine cannot outcompete the muscle, but my patient is still trying to contract their muscles, right? And so if we have this supply-demand mismatch, it's just going to make the patient weaker, okay? They're just going to get more tired, and they're going to get more fatigued as they go on. In Lambert-Eaton, because it's a blockade here, every time we contract, more calcium gets released from the sarcoplasmic reticulum, more calcium builds up here, it can outcompete that receptor, and now we can get the acetylcholine release that we were missing. And these receptors are totally fine. We bind to the acetylcholine to the receptor, and we continue on our sarcomere contraction cycle. So that's why myasthenia gravis usually gets worse with use, and Lambert-Eaton usually gets better with use. All right, really important topic right there. So make sure that makes sense to you. So again, here's just a side-by-side. We'll go through really quickly. But in myasthenia gravis, it's a postsynaptic acetylcholine receptor antibody. In Lambert-Eaton, it's a presynaptic voltage-gated calcium channel. Again, we just talked about the antibodies. Remember, we can also have that anti-MuSK antibody in myasthenia gravis. Classic weakness pattern in myasthenia gravis, it's ocular, so we see the ptosis, eyelid drooping, diplopia, double vision, bulbar, we could see the dysphagia or the dysarthria, and then we could have some generalized weakness. In Lambert-Eaton, it's more proximal legs and can actually impact the proximal muscles too. So difficulty standing or the proximal shoulders, so difficulty standing or climbing. Remember, reflexes are usually pretty normal in myasthenia gravis. They may be decreased or absent in Lambert-Eaton, but they can improve after activity, okay? Effective repeated use, remember myasthenia gravis gets worse as we work, as the patient is moving. That's because the postsynaptic calcium or the postsynaptic acetylcholine receptors are blocked, and we're not able to increase the amount of acetylcholine appreciably with muscle contraction, right? Whereas in Lambert-Eaton, the more I contract my muscle, the more calcium I release from the sarcoplasmic reticulum. The more calcium I have to outcompete those voltage-gated calcium channels, the more calcium that gets into the to the presynaptic axon terminal to cause snare protein to fuse, release acetylcholine, bind to the acetylcholine receptors, and initiate muscle contraction. So again, myasthenia gravis gets worse as we use them. Lambert-Eaton gets better as we use our muscles. Autonomic symptoms are rare in myasthenia gravis. They're common in Lambert-Eaton, so like dry mouth, impotence, constipation. Associated tumor in myasthenia gravis, check for a thymoma. In Lambert-Eaton, check for small cell lung cancer. The EMG response is decremental. It decreases in myasthenia gravis. We've already talked about why. And it increases. It's incremental in Lambert-Eaton. Again, we've talked about why. Bedside test, we can do the ice pack test or the tensilin test in myasthenia gravis. And then in Lambert-Eaton, if the patient's moving around, their strength will usually improve for the exact same reasons we've talked about before. Remember, the ice pack test and tensilin test has to do with me slowing down or blocking acetylcholine esterase, so we get more acetylcholine in the synaptic cleft, so we can outcompete those antibodies. Treatment is going to be pyridostigmine, steroids, IVIG plasmapheresis, and thymectomy in myasthenia. And then in Lambert-Eaton, we treat the underlying cancer. We can use 3,4-DAP, IVIG, or plasmapheresis. Our concern in myasthenia gravis is that myasthenia crisis. Remember, look out for beta blockers, aminoglycosides, fluoroquinolones, and magnesium is going to be the most commonly tested. Lambert-Eaton, it's less common for these types of crises. Demographics, again, classic patient to get myasthenia gravis are going to be younger women or older men. And then in Lambert-Eaton, it's classically older adults, especially smokers. Because remember, smoking really predisposes you to that central lung cancers. We always like to talk about squamous cell carcinoma and small cell carcinoma. Small cell carcinoma is the one associated with Lambert-Eaton. Can you remind me what squamous cell lung cancer is associated with? What paraneoplastic syndrome? So that's going to be humoral hypercalcemia malignancy via PTHRP. When I talk about PTH, I will talk about, or I do a hypercalcemia lecture, we'll talk about that. Okay, so if you want to read more, here's a couple articles I use to help build this lecture. So you can screenshot them, throw them into Google, and then I've got 2 putting it together cases, and then we'll be done. So putting it together, case number 1, this one will be on myasthenia gravis. We've got a 56-year-old man presents to the clinic for follow-up of generalized muscle weakness. 3 months ago, he was diagnosed with myasthenia gravis after presenting with diplopia, dysphagia, and fatigable limb weakness. Antibody testing confirmed anti-acetylcholine receptor antibodies and a chest CT revealed a thymoma, which he decided not to pursue resection at this time. He has been on pyridostigmine and low-dose steroids with symptom improvement. Today, he reports increasing fatigue and lightheadedness over the past few weeks. He denies bleeding, melena, or changes in diet. Physical exam shows pallor, but no jaundice, lymphadenopathy, or hepatosplenomegaly. His neurological exam is unchanged from baseline. Here's his labs. His hemoglobin is really low at 7.4. He's got a normal cytic MCV. His reticulocyte count is abnormally low, right? So normally when the hemoglobin's low, I'd expect the reticulocyte count to be elevated, right? I've talked about this in my MAHA lecture. We'll talk about it more when I do my hemolytic anemia lecture that further expands on that. The white blood cell and platelets are both normal. The peripheral smear shows normal cytic, normal chromic RBCs with no schistocytes, so probably not MAHA or blast. His LDH, haptoglobin, and bilirubin are also normal, which also point me away from hemolytic anemia. So we see the red blood cell count's profoundly low. He's got a normal white blood cell count, normal platelet count, very low reticulocyte response. What is the most likely explanation for his anemia, and how is it related to his underlying condition? So pause your screen, think about everything I just presented in this vignette, see if you can come up with an answer. All right, so whenever I think about thymoma, I think about 3 major conditions. Think about myasthenia gravis, pure red cell aplasia, and Good syndrome. And we've talked about myasthenia gravis, we'll talk about the other 2 here. So this patient likely has pure red cell aplasia. It's a rare autoimmune complication often associated with thymoma. So it classically causes an isolated normocytic anemia with a low reticulocyte count. The white blood cell and platelets are normal, hence the pure red cell aplasia. It is a selective destruction of the erythroid precursors in the bone marrow. So again, the thymoma disrupts our immune tolerance. We get autoreactive T cells that attack the red blood cell precursors. And so this can often occur with myasthenia gravis, and it reflects widespread T cell mediated autoimmunity. So again, we get these autoantibodies that are made in this abnormal thymus, where we're normally supposed to do our central tolerance process. Everything gets thrown off by this thymoma, okay? Makes these autoantibodies that then attack the erythroid precursors. So we're no longer able to make mature red blood cells, and we're not able to make reticulocytes either. The white blood cells and the platelets are totally normal. So whenever I see a patient with super low hemoglobin, their white blood cell and platelets are normal, and we've ruled out like a bleeding cause, we've ruled out everything else. Hey, we should consider a thymoma, okay? Pure red cell aplasia. If you want to read more, beautiful article right here. The systemic immunological disorders involving the non-motor symptoms in myasthenia gravis. Okay, so let's talk about Good syndrome really quick. Good syndrome is a paraneoplastic immunodeficiency associated with thymoma. It's characterized by low levels of immunoglobulins and impaired B and T cell mediated immunity. So the key features, again, it's associated with that thymoma. We have low immunoglobulin levels like IgG, IgA, IgM. We have decreased or absent B cells on flow cytometry. We often have low CD4 T cells and an inverted CD4 to CD8 ratio. We'll see recurrent sinopulmonary infections and chronic diarrhea. Remember, IgA is really important. It's my king of my mucosa. So that helps protect against respiratory infections, upper respiratory, lower respiratory, and GI are going to be really susceptible if I don't have IgA. It may coexist with other autoimmune diseases. And again, the mechanism here, same as before. The thymoma disrupts the central T cell tolerance. It leads to abnormal T cell maturation and failure of B cell development and survival. It results in low B cells. So therefore, we have low immunoglobulins. We have low CD4 T cells, which alters the CD4 to CD8 ratio. And then the T helper cell support is really low. So we don't have that support for the antibody production. This is really important because obviously when I think about this kind of patient, like it's going to show up in like a adult of some sort, probably, right? They're going to have this low level of CD4. They're going to have a low level of immunoglobulins, and they're going to be chronically infected. What should we think of right off the bat? Well, we should think about HIV. We should think about, do they have a history of transplantation? Should we work them up for CVID, right? Combined variable immunodeficiency, right? We should do all those. And then we should consider, hey, do they have a thymoma, right? Or maybe you see all this and for some reason you got a chest CT and you see a mass in the area of the mediastinum, the thymus, right? We should consider Good syndrome, okay? This will require IVIG infection or IVIG replacement and then infection monitoring, okay? Kind of just like CVID, okay? CVID I've talked in other lectures. All right, so remember thymoma, we think about myasthenia gravis, pure red cell aplasia, and Good syndrome. Three really, myasthenia gravis, obviously the most high yield out of those. Red cell aplasia and Good syndrome can help if you want to score, the 99th percentile for step 2. I would know both of those. So let's finish it up here. Putting it all together, number 2. We've got a 64 or 65-year-old man with a 40-pack year smoking. He presents with progressive difficulty rising from chairs and climbing stairs over several months. He also reports dry mouth, constipation, and recent erectile dysfunction. Neurological exam shows symmetric proximal muscle weakness or leg weakness, diminished deep tendon reflexes, and mild improvement in strength after brief exertion. So you probably already know where this is going. His electrophysiological testing reveals an incremental response with repetitive nerve stimulation, and his anti-voltage gated calcium channel antibodies are positive. Chest imaging reveals a central lung mass, and biopsy confirms small cell lung cancer. He started on chemoradiation. Several weeks later, he develops new neurological symptoms. He has difficulty with short-term memory. He has gait instability, numbness in his feet. Exam shows impaired coordination, reduced vibratory sensation, and bristle reflexes. MRI brain shows increased signal in the medial temporal lobes, and CSF fluid analysis is pending. The patient with small cell lung cancer and Lambert Eaton is now experiencing progressive neurological dysfunction with a paraneoplastic encephalitis and sensory neuropathy. So I want you to think about, what is the pathophysiological explanation for his new neurological symptoms and how does it relate to his underlying malignancy? So pause your screen, reread the vignette if you need to, and think about it. So this guy has paraneoplastic encephalitis, or sometimes also can be referred to as autoimmune encephalitis. They're technically two different things. They often have some sort of overlap, but this is caused by small cell lung cancer, okay? Small cell lung cancer can express neuronal antigens. Anti-Hu is going to be a really important one here. The immune system attacks the tumor, but it cross-reacts with the nervous system via molecular mimicry. So my immune system sees these Hu proteins. It makes antibodies against them, and it attacks the Hu proteins. Unfortunately, some of our proteins in our brain look awfully similar to the anti-Hu protein, and my body can go and attack them too, especially in the medial temporal lobes. That's classically where the Hu proteins live, and in my peripheral nerves, okay? Because that's how these patients are going to present. They're going to present with an autoimmune or paraneoplastic encephalitis and peripheral neuropathy. So again, the autoantibodies plus T cells target the CNS and the PNS, and we get these paraneoplastic neurological syndromes. So again, Lambert-Eaton we've talked about in depth. We get the anti-voltage gated calcium channel. We'll see the proximal muscle weakness and autonomic symptoms. We'll see this limbic encephalitis. So remember my limbic system, especially in the temporal lobe. Classically, these anti-Hu antibodies, we can see memory loss, hippocampus, seizures, mood changes, and then we can get the sensory neuropathy too with the anti-Hu and the anti-CRMP5. So we can see numbness, gait ataxia, and areflexia. So people with small cell lung cancer, if I ask anyone, any M1 or M2, what's the associated paraneoplastic syndromes with small cell lung cancer, they could easily probably rattle off for sure Cushing, ACTH, for sure hyponatremia, ADH. Maybe if you get a good med student, they'll rattle off Lambert-Eaton syndrome, and then I always tell them, I'm like, hey, there's one you're missing. They always get 2 or 3 out of the 4. I'm like, there's always one you're missing. And as always, everyone forgets all about encephalitis and neuropathy secondary to anti-Hu. So again, small cell lung cancer can secrete ACTH and cause Cushing syndrome. When I do my hypercortisolism lecture, we will talk all about this. I've already talked in depth about hyponatremia. Go watch my hyponatremia lecture. But small cell lung cancer can secrete ADH. It'll cause a euvolemic hypotonic hyponatremia. The urine osmolality will be greater than 100. The urine sodium will be greater than 40. If you're like, what the heck's going on here? Go watch my hyponatremia lecture. You'll figure it out. Lambert-Eaton, we've talked all about. And then encephalitis or neuropathy due to these anti-Hu, we impact the medial temporal lobes and my peripheral nerves. All right. We covered a lot. We covered neuromuscular transmission, the sarcomere contraction. We talked all about myasthenia gravis, all about Lambert-Eaton. We talked about thymomas. We talked about small cell lung cancer, all in 45 minutes. This should be the only lecture you'll ever need on all that information. Hopefully it helps you. Please reach out with email and ask me any questions you got and any topics you want covered. Until next time.